for joining us for today's CHD Wise. My name is Carissa Ostrom, and I'm the Executive Director of Conquering CHD, and I will be your moderator for this webinar on CHD and pregnancy. On today's episode, we welcome two experts from Children's Wisconsin, as well as two adult congenital heart patients who have gone through multiple pregnancies of their own. We have Dr. Scott Cohen, who is the Program Director for the Adult Congenital Heart Disease Program at the Herma Heart Institute, as well as an Associate Professor of Cardiology at the Medical College of Wisconsin. We also have Dr. Sarah Creighton joining us, who is a cardiologist focused specifically on fetal heart medicine at the Herma Heart Institute, as well as an Assistant Professor of Pediatric Cardiology at the Medical College of Wisconsin. And the two patients who are joining us today are Cassie and Steffi, who are sisters and have been patients of the ACHD and fetal heart programs at the Herma Heart Institute for many years. Thank you all for being here today to talk about pregnancy for adult CHD patients. And I believe our first question will go to Scott. What can cardiac patients do to prepare for pregnancy?
All right. So for our patients that are adult congenital heart disease patients, as they're thinking about having a pregnancy, I think one of the most important things they can do is have a good routine follow-up to make it through all their appointments, see their cardiologist specialist, make sure that they're up to date on all of their routine testing, because some of these women may have a higher risk of cardiac problems during pregnancy. And so we would usually advise them to make sure that these pregnancies are planned so that we are up to date on knowing what their heart function is like, what all their valves are like, and making sure that we can minimize whatever risk they may have associated with a possible pregnancy. And so routine testing, such as imaging like echocardiograms or MRIs. Sometimes we do stress tests as well. Sometimes we do lab testing in terms of blood counts or kidney function or looking at anticoagulation. And so then during these clinic visits, we often discuss things like what their risk may be during a pregnancy. We discuss things like medication and whether or not there would need to be any medication adjustments. And then for some women, we also talk about contraception. If there are certain types of contraception that would be more safe for a woman with specific type of congenital heart disease. The frequency of the visits are, in terms of preconceptual counseling, are usually dictated by the type and severity of congenital heart disease of the patient. So women that have more complex congenital heart disease, typically we see those women more frequently, and we'll talk about risks related to a potential pregnancy. We talk about medication changes. Sometimes medications that a woman is on may not be safe during pregnancy, whether it be for the woman or for the developing baby. And then we also will talk about the normal changes in the cardiovascular system that occur during a pregnancy and how that can affect the woman's heart and potentially cause a risk of certain types of heart problems during a pregnancy. And we also talk about how sometimes symptoms or signs of cardiovascular problems during a pregnancy, such as shortness of breath or increased swelling, can actually be similar to the normal signs or symptoms that women feel during pregnancy, and how we would then go about trying to differentiate whether or not it's normal signs or symptoms of a pregnancy versus something that we should be more concerned about related to the woman's heart.
So for patients who have adult congenital heart disease, what are some of the risk factors associated with pregnancy?
Yeah, so overall, women tend to do very well during a pregnancy if they have congenital heart disease. However, there are some women that may be at a higher risk of having some adverse events during pregnancy. And so overall, this is data just showing overall adverse events during pregnancy or pregnancy outcomes in women with congenital heart disease. So we know that about 1 out of 5 pregnancies tend to end in either a stillbirth or a miscarriage. About 1/4 of women may have a cardiac adverse event, such as heart failure symptoms or arrhythmia, and typically heart failure symptoms or what's called pulmonary edema is the most common in about 15% of women, and that typically is manifested as feeling more short of breath with activities. And then from a neonatal perspective, we know again about 1/4 of neonates born to women with congenital heart disease may have some type of adverse event. So that may include something like preterm delivery, which is the most common. And then most, or I should say least common, are things like fetal demise or neonatal death. And we know that, we can move to the next slide. We know that we try to risk stratify women in terms of who will be at a higher risk of having some of these adverse events, whether it be from the women's cardiovascular status, an adverse event like heart failure symptoms or arrhythmia, or who may be at a higher risk of having neonatal adverse events, whether it be preterm delivery or miscarriage or other obstetric events like preeclampsia or such. And so there's been many studies over the last 10, 20 years or so that have looked at what are some high-risk findings that we can use to kind of try to figure out who will be one of these higher risk patients. And so these high-risk findings are things such as having a prior cardiac event. So if a woman has had heart failure in the past, or has had a heart attack in the past, or has had a stroke in the past, that woman may be at a higher risk of having similar events during a pregnancy. If there's significant obstructions of blood flow in the ventricle, which is the pumping chamber of the heart. So if there's severe tightening of a valve that obstructs blood flow out of the heart, that may be a high-risk finding. Women that tend to have symptoms related to their heart disease prior to pregnancy. So if they're starting out already having a lot of shortness of breath with activity or having a lot of rhythm issues prior to pregnancy, they're going to be at a higher risk of having more of those symptoms during a pregnancy and possibly needing increase in their medical regimen during a pregnancy. If the squeezing function of the heart, the ventricle, that pumping chamber, if that squeezing function of that pumping chamber is reduced, that could be a high-risk finding. So that EF less than 40% represents a way that we describe the pumping chamber. EF means ejection fraction, and that's the percentage of blood that is estimated to be pumped out with every squeeze of the heartbeat. Normally it should be somewhere between 50 and 70, and so being under 40% is thought to be a risk factor. If women tend to have cyanosis, which is low oxygen levels, that could be a risk factor. Or if they have what's called severe pulmonary hypertension, that's the pressure in the lungs. If that's severely elevated, that could also be a risk factor. A common syndrome that we see in terms of congenital heart disease and having severe pulmonary hypertension is something called Eisenmenger syndrome. And that is a very high risk cardiac condition prior to pregnancy. There are conditions called connective tissue diseases, which affect the ability of the blood vessels to stay a normal size. So something called Marfan syndrome is a example of a connective tissue disease. Other things like Ehlers-Danlos, specifically vascular type, or Louis-Dietz syndrome, those are all connective tissue disorders. So having large aortas in the setting of having connective tissue disorders could also be a high-risk finding. More recent studies have shown that severe pulmonary insufficiency, that's a valve in the heart, the pulmonary valve. So if that valve leaks a severe amount, or if that ventricle that pumps blood through that valve is not working well, that has also been shown to be a high-risk finding. And then a couple more, if a woman has had a pregnancy that ended in what's called peripartum cardiomyopathy, that's a weakening of the heart muscle that we see during pregnancy in a few women. It's fairly rare, but if there's a history of peripartum cardiomyopathy, having another pregnancy after that can increase the risk of, again, having a decrease in heart function during the pregnancy. And then finally, having a history of mechanical valve replacements is also thought to be a high-risk finding, because these women typically are on blood thinners like warfarin, and we know warfarin can affect fetal development and cause risk of fetal problems during the pregnancy, as well as there's a risk of the mechanical valve being not working very well during a pregnancy. So we have to take a lot of care in making sure that women with mechanical valves on blood thinners are adequately anticoagulated during a pregnancy. And so we take all these risks that I just mentioned, and we have all these risk stratification schemes. This is one of the more common ones that was published a few years ago, called the CARPREG-2 risk stratification scheme. So we tally up the number of these risk factors a woman may have, and typically these risk factors get assigned a certain number of points, and we tally up those points. And it's been shown that women with a certain number of points may have a certain percentage of a risk during pregnancy. So if a woman has 2 points because of a certain number of risk factors, then that woman, based on this graph, would have about a 10% risk of having something like heart failure symptoms or a rhythm problem during pregnancy, or even in the weeks to months soon after pregnancy. So there are a couple different schemes that we can use, very similar to this one, but this is one of the more common ones that we use. And this helps us give a specific percentage of a risk related to pregnancy, and can be very patient specific.
Thank you for sharing that information on the risks associated with CHD and pregnancy. Now I would like to invite Steffi or Cassie to kind of talk about how you prepared for your pregnancy.
I'll go ahead. I'm Cassie. So when we initially find out we're pregnant, we usually meet with our regular OBGYN. And once we meet with them, they kind of contact the cardiologist and then also put in a referral to the high-risk OB. And then our blood thinner, the warfarin, is stopped, and we are then transitioned to the Lovenox injections. So between the high-risk OB and the cardiologist, they kind of collaborate and take care of our Lovenox injections. And then we always check our levels, so they kind of monitor that. And for my first baby, I mean, I obviously never gave injections to myself. So one of the RNs taught us how to administer the Lovenox injection. So that was super helpful. And then just following up with all your appointments, like us getting our echoes, getting the ultrasound at our high-risk OB, and then following up with our regular OBGYN is super helpful, making sure us and baby are always safe. And then usually around in between 30 and 33 weeks, going down to Freighter, and then coming up with a birth plan. So that's kind of usually how it goes.
Thank you for sharing your experience with that. We are going to move on to Sarah. And what are the odds that a CHD patient's baby will also be born with a congenital heart disease?
Yeah, thanks. So the picture up that I put up there is actually from a paper of the guidelines that we utilize for the diagnosis and treatment of heart disease. It's the best table I have, though it's about 10 years old, and we just updated the guidelines. It's still the best looking one. As a fetal cardiologist, when I see moms that have heart disease and come in general, we can say it's somewhere between 3 and 7% of babies where there's a first degree family member, usually mom in my case, has heart disease, will also have heart disease. So somewhere between 3 and 7%. When you compare that to national, what the overall likelihood of a baby having heart disease, that's about 1%. So I tell people that you can look at it in different ways. One, you can look at it as well, that still means 93 to 97% of kids born from moms that have heart disease will also not have heart disease. So most of them will not. You can also look at it in another way, that's 3 to 7 times higher than the national, than the kind of the overall incidence. And so as cardiologists, as fetal cardiologists, we utilize that number in saying, well, that's much higher than the kind of overall population, so we should look at all of them. And we'll talk about that a little bit later too. But just overall, we say 3 to 7%. That being said, there are certain heart diseases where it's more common. So patients with bicuspid aortic valves, particularly, that risk for passing that on to another, to a child, is somewhere around 10% from the recent data. And then there's some things like atrioventricular canal type defects where it might be a little bit higher. And there are certain defects where heart defects where it might be a little bit lower. That's including things like transposition of the great arteries. Some of this is because some of these heart diseases are linked to genetic abnormalities. So if the parent has a genetic abnormality, that can be then passed on, and that incidence can be a little bit higher too. But overall, 3 to 7%.
So Scott, how do you typically monitor your patients during pregnancy?
Yeah, thanks. So I think in terms of trying to figure out how we monitor patients during pregnancy, it's important to know what are some of the cardiovascular changes that occur during pregnancy, because these are the changes that can affect the woman's heart and therefore will dictate maybe how frequently or what type of testing we would do during a pregnancy. So during pregnancy, it's normal that there's an increase in blood volume because now not only does the woman's heart have to supply blood to her own body, but now she also has to supply blood flow to the developing baby's body. This increase in blood volume actually increases the workload for the heart. So the heart typically has to pump more volume per minute than it did in a non-pregnant state. And there's also a drop in blood pressure as well, particularly in the first couple trimesters. Usually then in the third trimester, the blood pressure tends to come back up to the normal range, but it's not uncommon to see the blood pressure fall lower than what the woman may be used to seeing in the first first 2 trimesters. So because of this increased work and the changes in blood pressure and such, women that have certain types of heart disease and some of those risk factors that I mentioned a few minutes ago may be at a higher risk than for some of these adverse cardiac events because the heart is working harder. And so during pregnancy, we will have follow-up visits throughout the pregnancy. Sometimes we would meet every trimester. Sometimes there would be maybe once in the second trimester. And as long as the woman is doing okay, no more follow-up is needed. And so really the frequency of that follow-up during the pregnancy really depends on the severity and the type of congenital heart disease that woman has and how she is doing during the pregnancy. Sometimes we'll repeat echocardiograms depending on the type of congenital heart disease the woman has. So those changes of pregnancy I just mentioned, the increased workload, the increased blood volume, those changes tend to peak around the end of the second trimester or the beginning of the first trimester. So frequently we will do, if we're going to do another echocardiogram, we'll do that at around 28 to 32 weeks, because that tells me how is the heart handling that increased workload that it needs to do during pregnancy. And during these visits, we'll often check on symptoms. How are you doing in terms of being able to complete your normal activities of daily living? Do you have more shortness of breath than you're used to? Or if you've had prior pregnancies, how does this pregnancy and symptoms such as shortness of breath or swelling, how does it compare to prior pregnancies? Is it more than what you would expect? We'll talk about medication. So do we have to make any adjustments on doses? Do we have to add new medications? We'll talk about whether they need to have a fetal echocardiogram, depending on where we are in the pregnancy. And then very, very rarely, some women will need to have procedures during the pregnancy. If they have a valve that's very, very tight and is causing more symptoms of shortness of breath or heart failure symptoms, sometimes we actually do a procedure on that valve, not a big open heart surgery, but sometimes in the cath lab, we can do procedures on valves during pregnancy. If they're having rhythm issues and they're in a sustained heart rhythm that we think is not safe for the woman or for the baby, sometimes we can do procedures to get them out of that heart rhythm. So there are rare times that we may recommend doing certain procedures during a pregnancy, and these are things we would discuss during these follow-up visits.
Our next question goes to Sarah, and who should be having fetal echoes during pregnancy and how often?
It's a great question. For indications, there's a variety of indications that, and a variety of reasons that babies can, pregnant moms can come and see me in the fetal clinic. There's maternal factors, as Dr. Cohen had stated. The family history of congenital heart disease or congenital heart defects is a strong indication to get a fetal echo for screening purposes. We specifically say a first degree family member, so that is one of the parents or a sibling should have a fetal echo. Certain maternal diseases, not just heart disease, though, can also be an indication for a fetal echo. That can mean that if mom has diabetes, we say pregestational, that means before pregnancy, either type 1 or type 2, increases the likelihood that a baby will be born with congenital heart disease. A maternal disease called phenylketonuria, especially if it's not controlled, can increase that likelihood. And certain types of diseases, one is called Sjogren's. Sometimes patients with lupus have specific antibodies in their body that can cause damage to the fetal heart after going through the placenta. Certain infections that moms can get during pregnancy, one particularly is rubella, that can cause damage to the fetal heart. And then medications that mom is on while pregnant can increase the likelihood of heart disease. Retinoids, those are vitamin A supplements, so ones that some people take for acne, can be a medication that puts babies at risk for developing heart disease during development. Certain types of blood pressure medications, one called an ACE inhibitor, and then a anti kind of depressant medication called paroxetine are just a few examples. There can be baby factors that cause referral for fetal echocardiograms. One really common one is, or not very common, but one reason is called hydrops, that there's extra fluid in and around the heart or lungs or in the skin of baby that indicates that the baby is distressed, and looking at a fetal echo is one of the reasons to try and figure out why. If the baby has outside of the heart abnormalities, kidney, brain, belly abnormalities, those frequently will also be referred to look closely at the heart in a more detailed fashion than the standard anatomy scan. If there's abnormal genetic testing where we know that there's a high risk for heart disease, these mean things like Down syndrome or trisomy 21, abnormalities in chromosomes 18 or 13, deletion syndromes, including something called 22q11. Some people call that DeGeorge syndrome as well. And there are some other higher risk genetic abnormalities that also come up. And then a certain type of twin pregnancies, these are called monochorionic diamniotic twins, where they can share blood flow through the placenta, and one baby can give the other baby blood flow that can cause too much blood flow in the baby's heart and cause that heart to be very stressed. So we'll see those. The biggest reason that we get referrals, though, for fetal echocardiograms is if there's an abnormal anatomy scan or there's a concern about the heart itself. And so obviously, if there's a concern about the heart, they come to see us in the fetal cardiology clinic to not just diagnose the heart disease, but counsel family as well as make sure that we have a safe birth plan.
So what type of defects are usually found during a fetal echo?
So about 70% of congenital heart defects are now found by fetal echocardiogram. And the ones that are missed are usually those that are just not picked up in the anatomy scan. But we can see all types of fetal cardiac disease, from small holes between the chamber all the way to complex diseases where lots of the plumbing is not hooked up in the standard fashion. And so we can find quite a variety, though that we do know that somewhere between a quarter and about 30% can be missed in the prenatal period, partially because of limited views. And if we're having a hard time seeing the baby's heart, but also because of some of the factors that we can't predict. There are certain heart diseases, particularly narrowing of the aorta, called coarctation of the aorta, that can be very difficult to diagnose in pregnancy and can look very normal early in pregnancy and then look more concerning after birth. And so because of that, we have high levels of suspicion, but overall we can diagnose most types of heart defects before birth when we get to see them.
Thank you for sharing that. Staffy or Cassie, what was your experience like going through pregnancy as a CHD patient?
Hi, I'm Steffi. So pregnancy is obviously scary and nerve-wracking to begin with. And then when you add in the heart and the risk factor that my sister and I had, it's a bit overwhelming. But seeing our regular OB, our high-risk doctor, and our cardiologist, Dr. Cohen, it brought us peace of mind throughout the pregnancy and made myself and my sister feel more confident that we were getting the best care possible and that our babies were being watched and that everything would, be okay. One of the scariest parts of it was the blood thinners, like just transitioning to the Lovenox injections. So that was a bit intimidating, but knowing that the doctors were watching us so closely and making us getting our levels checked so often and keeping an eye on that was reassuring. Getting those fetal echoes that Dr. Creighton just talked about was also reassuring because we are both CHD patients. All of our children got checked around 25 to 30-ish weeks when we were pregnant. So that made us feel better to have their hearts checked, even though they're so tiny at the time. But that was always reassuring as well. And then going down to meet with the maternal fetal medicine team down at Freighter, we did that around 30 weeks. And that always brought peace of mind as well, because we met with the anesthesiologist, the cardiologist, like the whole team down there that walked us through how our labors and deliveries would go and just all of the details that went along with that. So yeah, I mean, we're so grateful for the team and all the doctors that got us where we are today. We're so blessed.
Thank you for sharing your journey with us. Dr. Scott, how do you manage a heart patient during labor and delivery? What method of delivery is most appropriate, and can a patient deliver at home?
All right, so good questions. So I mentioned a number of changes that occur to the cardiovascular system during pregnancy. Well, even more changes occur during the time of labor and delivery. And there's just more work generally, again, that the heart has to do during labor and delivery. So just the uterine contractions during labor cause more blood flow to be pushed, or more blood to be pushed into the cardiovascular space, which increases the amount of work the heart has to do. Positioning of the woman during labor and delivery, sometimes we recommend laboring on the side, and sometimes we're okay with laboring on the back, but that all can affect the way that the heart gets blood back to it from the body, and that can affect how women will do during labor and delivery. Pain and anxiety during labor and delivery can obviously increase the heart rate and increase the blood pressure. So of course that can also increase the amount of work the heart has to do. And then bleeding. So bleeding can cause all of a sudden a very big drop in the amount of blood that's there for the heart to pump, and can cause a lot of problems with blood pressure. And so we have to take that into account. And then we take into account the type of anesthesia or analgesia, which is pain medicine, and how that affects the heart and cardiovascular system. Sometimes these medicines can cause dilation of blood vessels and blood pressure drops. And so we have to take that into account. And then finally, with whether it be vaginal deliveries or with C-section, there could be a risk of infection. And infection can definitely impact the heart and the cardiovascular system. People that have very severe infections can have drops in blood pressure and need more fluids and such through IVs and antibiotics. So all these things we have to take into account when trying to decide how we're going to recommend women go through labor and delivery. Next slide. So some of the questions that we ask ourselves and our teammates in terms of the OBGYN and the maternal fetal medicine doctor, the OB anesthesiologist, and some of the things that we communicate to our patients are, number one, is this woman safe to have a vaginal delivery, or should she have a C-section? And I think it's important to know that many women, almost all women with congenital heart disease, can have a vaginal delivery. C-section is really only reserved for obstetric indications, or there's a very small number of cardiovascular indications where potentially we would recommend the C-section over a vaginal delivery. And those would be indications such as in those connective tissue disorders I mentioned, like Marfan syndrome or Lewy Dietz, if their aorta is very enlarged, sometimes it may be safer to do a C-section for those women. Or if a woman is having symptoms, having poor blood pressure control, whether it's too low or too high, or if they're having heart failure symptoms at the time of labor and delivery, potentially at that point, it may be safer for the woman to undergo C-section. And this may be surprising to a number of individuals that vaginal delivery is thought to be safer, but a C-section is a big surgery. It's a big abdominal surgery. There can be a lot of shifts in terms of the fluids in a woman's body during big abdominal surgeries. There's risk of infection, there's risk of bleeding. So all these things tend to make C-section potentially a little more risky for some women than a vaginal delivery. So the next point that we try to tackle is what type of anesthesia does the woman need, if anesthesia at all. So generally we talk about regional anesthesia. So that's something like an epidural or spinal block, or there's something called general anesthesia, which is when the patient is totally put asleep and put on a mechanical ventilator to help her breathe during potentially a surgery like C-section. Many women can undergo anesthesia with a regional anesthetic, like an epidural or a spinal, and not need general anesthesia, even in the setting of a C-section. There are times that we actually do recommend having an epidural rather than no anesthesia at all. So women that have some of these higher risk findings, such as obstruction of blood flow moving out of the heart or a weak heart muscle, sometimes we'll recommend having an epidural, because epidurals can block that adrenaline rush, that the pain and the anxiety that can occur during delivery, that causes an increase in heart rate, increase in blood pressure, that causes more work on the heart. Sometimes by placing an early and good epidural, that can block the body's response, that increased adrenaline response. Sometimes that can help lower the risk of some of the complications we can see. We also talk about whether it's safe to push, or whether or not a woman would need a facilitated second stage, which is using something like vacuum or forceps assistance. So there are times where we would recommend not pushing, or having just a short trial of pushing, but having a low threshold to having a facilitated second stage. So these are some of the same type of reasons we would recommend like an epidural. So if there's severe valve tightening, or if there's low heart function, if they have high pressure in their lungs called pulmonary hypertension, like I mentioned before, if there's a dilated aorta that maybe we wouldn't say you need a C-section for, but it's dilated enough that we want to minimize the amount of work and stress that's on the heart and the aorta. And then there's a certain high complexity type of congenital heart disease called Fontan, which means that there's one chamber of the heart that does all the pumping of the heart. And those are high risk patients that we would often recommend either a limited trial of pushing or potentially a facilitated second stage. Other things we think about are use of telemetry, which is rhythm monitoring during labor and delivery. It's a couple stickers that the patient would wear while she is in the hospital room. And we recommend that for women we feel would be at a higher risk of rhythm problems during labor and delivery, so that we could see that very quickly and act on it very quickly as well. In terms of blood pressure monitoring, are we okay with just routine blood pressure on the labor and delivery floor, where they maybe check the blood pressure once every shift? Or sometimes if we're really concerned about blood pressure changes or the risk of decompensating and having heart failure problems, sometimes we actually recommend invasive monitoring, which may be something like having a special type of catheter inside the radial artery, the artery that we tend to feel our pulse on in our wrists. We can put a special catheter in there that monitors the blood pressure in time. So second by second, we could see what the blood pressure is doing. And potentially even more rare, sometimes we do special catheters in some of the veins in the neck that helps us monitor the pressures in the heart during labor and delivery. And then other things we think about are, does the woman need to have antibiotic prophylaxis? So if she has something like a mechanical heart valve or a replaced valve, or sometimes other types of congenital heart disease that may put the women at a higher risk of having an infection in the heart called endocarditis, we'll recommend giving antibiotics prior to labor and delivery. And usually that's in the form of IV medication at the time of labor and delivery. And then finally, do we have to monitor anticoagulation? Is the woman on anticoagulation, whether it be because of a valve replacement or rhythm problems or any other reason why women may be on anticoagulation? How do we manage that during labor and delivery? Because there could be an increased risk of bleeding during labor and delivery. And in terms of delivering at home, I think the place that we recommend for delivery kind of, again, depends on what the severity and complexity of the congenital heart disease is and how the woman has done during their pregnancy. Typically, if a woman is seeing me as a cardiologist in clinic, it's because there's some concern about whether or not she may have an adverse event from the heart and cardiovascular system during labor and delivery or during the pregnancy and labor and delivery. So because of that, I usually would recommend the woman have her labor and delivery in a hospital. Sometimes I feel like they're at fairly low risk of significant adverse events. I would be okay with a woman delivering at a local hospital rather than, coming to Freighter where we're around. But if I feel like they're at low enough risk, I'm okay with them delivering at maybe a hospital closer to them. But delivering at home, I think, really would potentially pose a higher risk that if something were to happen at home, I don't know if I would feel safe with them having appropriate care and monitoring at home. But these are discussions that I would have with the patient as well as with the rest of the members of our team, like the maternal fetal medicine doctor, the OB anesthesiologist, and a fetal cardiologist like Dr. Crichton, to see if we felt that the woman would be safe enough to have a home delivery.
I want to pose the same question to the fetal side of things with Dr. Creighton, and how do you manage the delivery of a baby with CHD, and what method of delivery do you think is best?
Yeah, so I think on the maybe next slide, I have kind of my version. As a fetal cardiologist, we obviously look to diagnose the heart disease, and then we obviously counsel family, but then risk stratify. And when we risk stratify the type of delivery, we look at, Dr. Cohen really well described the risk factors for mom to go through, not just the cardiac disease, but there's other obstetric factors that can impact the type of delivery. But overall, from a fetal cardiac standpoint, if the baby has heart disease, most of the time I recommend whatever is safest for mom and baby. And so if the OB team says that mom can deliver vaginally, 99% of the time, babies with heart disease can also deliver vaginally. They can tolerate labor well because circulation before babies are born is generally very stable. And it's very few instances where the heart disease is so severe where we can, they would be at risk for having a problem with the delivery process itself. Those that cannot deliver by vaginal delivery are those where the baby before birth, their heart function is very severely impacted, so their heart is not squeezing well, and we worry that baby's going to look very sick when they come out. Sometimes the heart is not squeezing well because of a heart rhythm factor, and that can be a reason that we would recommend C-section to be able to not have the baby undergo stress, and we wouldn't be able to monitor the heart rate very well if the baby's heart rate is already abnormal. The final reason we would recommend C-section, one of the few reasons we would recommend C-section over vaginal delivery, is if the baby requires, their fetal circulation is stable, but as soon as they come out, they could be exceedingly sick and need to go to the operating room immediately. This is a very high-risk delivery. We call these impact procedures, where they might need ECMO or surgery immediately, and happens exceedingly rarely. And is something that is a very coordinated effort. And the reason for the C-section is not because baby wouldn't tolerate the delivery process, but we want all the team members there, including the congenital heart surgeons, to be there and ready so that the baby has a minimal amount of time with poor blood flow. When we talk about, so most of the time, vaginal deliveries are indicated for fetal heart disease, for babies with heart disease. The reasons we would talk, though, about home versus other types of delivery is very much dependent on the heart disease itself. So one is when we talk about delivering at we call it a tertiary, or a site where they can do heart surgery or have a high NICU level, versus at one of their local hospitals, would be what support services does that hospital have? Do they have the ability to get an echo? Do they have cardiologists that can talk to the pediatric team? The other factors we look at are the baby factors themselves. What type of heart disease do they have? Do they have something where they're going to need surgery or procedure within the first week or two after birth? At that point, we may say delivering if they need heart surgery really quickly or need medication so that they don't get sick after they get born before a surgery, then we recommend delivering them at a site where they can do the heart surgery, because we don't want to separate mom and baby. That dyad between the mom and baby is really important, and that separation is not just hard on mom and family, but also hard on the baby. If there's outside of the heart abnormalities, sometimes that impacts where we recommend delivery as well. So if they have heart disease, but also brain and kidney or stomach issues, those can impact where we deliver that. If the heart disease is more mild, but the stomach and kidney disease is really severe, then they may need to deliver at a site where there's more services available. And then the likelihood that they will kind of get through transition without getting sick is another factor. And so when we come up with that, we have actually, as a fetal cardiologist, we kind of give a number score to the baby, kind of like Dr. Cohen talked about a risk score for moms early in this talk. And the next slide, this is not something I want people to really read really closely, but this is ours at Children's Wisconsin that we use based on some national data that really started out of Children's National in Washington, D.C. But we assign a number score to the baby with how high of their risks, how high is a baby's risk factor to get sick, and what will they need after delivery, so that the whole team knows what they will need. Will they need IV lines? Will they not need IV lines? And then we can look at the hospital services that are required and decide where's the best place for the baby to deliver. So sometimes I can say, with more mild disease where I don't think baby will need something immediately or in that first week or two after delivery, that they can deliver at a local hospital and follow up as an outpatient. sometimes the heart disease is severe enough where I know they're going to need, the baby will come out looking really good, but will need something after they deliver. And so we'll recommend delivery at one of the at a surgical center where mom and baby can be close related. As for delivering at home, just like Dr. Cohen said, for me, when we see something abnormal about the heart, it does mean that there can be risk factors that we can also not always see. We know we're not perfect in fetal cardiology, and the physiology of the blood flow changes from inside to outside that can unmask things that we don't always anticipate. And so when they're seeing me and I do see significant heart disease, delivering at home makes us concerned because generally it's you have the obstetric delivery component from typically a midwife, but there's nobody to watch the baby really closely as the mom transitions. And so if there's something going on with the baby, you have one person usually torn in two different directions. And then being able to watch that baby transition sometimes makes us nervous from the fetal standpoint. There are diseases that are exceedingly mild where we would encourage a discussion with the obstetric team and as well on what that any risk factors if the baby has a very, very mild heart disease that we think may self-resolve over time. And that might be more of a discussion between the obstetric team, and as we don't think the risk to babies are low, or we think the risk to the baby is very low. So it's very dependent on that. But I would say in general, if they're seeing us with significant heart disease where we think surgery is indicated, at one point we probably would not recommend at home, but we may be able to deliver at a local hospital.
Cassie, can you walk us through your experience with labor and delivery?
Yeah, so for all three babies, I was induced at 39 weeks. Usually went down to Freighter like 1 to 2 weeks before that 39-week mark. And then once we're admitted at Freighter, our Lovenox is stopped and then heparin drip is started. And then they start the induction at the 39 weeks. And once the contractions start, usually that's when the heparin drip is stopped. And I did have vaginal births for all three of my babies. And then once the baby is born, the heparin drip is then started again. And I will say with my last baby that I just had, I was able to get the epidural. So they just have to time it out right where we stop the heparin drip. Usually I think it was around 4 hours. Then I have to get my level checked. And if it's in range or it looks okay, then it's appropriate to get the epidural just for the bleeding risk too. But with my first two, I did not get the epidural. So I think after each pregnancy, you kind of learn from the previous one or the previous one before that, just so that things go more smoothly. But I think everything went well with all three of them.
Thank you for sharing that. And Steffi, what was your experience like navigating both your own heart journey as well as your child's?
So I was born with a bicuspid aortic valve. So as discussed earlier, there's obviously a risk that my children would have it. So I have 4 kids. Right after they got the fetal echo around the 25 to 28 week mark. And then also after I delivered, they all had echocardiograms within like 24 hours of being born, because bicuspid aortic valve is something you're born with. It doesn't develop. So of course, you always like think the best, or try to. I do. So I never thought it would actually happen, but it turned out that my second child, whose name is Cole, was born with it. So I found out like pretty much right after delivery that he had this. And obviously it's not something you want for your child, but being a CHD patient myself and knowing what he's in for his life and the tests that he will get, the echocardiograms, EKGs and all of that, it brings me peace of mind that I can be there for him. And I have the utmost faith in Dr. Creighton and the team at Children's. So yeah, it's not an ideal situation, but it's nice to know about it ahead of time, not something that he finds out later in his life. And then who knows what could have happened at that point. So it's good to be ahead of the game and know that he's being watched by some amazing doctors.
Dr. Cohen, what are some of the long-term effects that pregnancy can have on a woman's heart?
Yeah, so I thought I would start off with just quickly mentioning that labor and delivery isn't the end of where we have to just have a high awareness of potential cardiac problems when it comes to pregnancy. So when the baby is born, there's still usually a couple weeks to even a couple month period of time where there's still increased workload for the heart. So once that baby is born, the work for the heart still increases, actually. It's still up about 80% over what a pre-pregnancy level for heart workload is. And that's because of a couple of reasons. One is that uterus has that, final contraction where it's contracting down, involuting back to its normal size. And as it does that, it pushes more blood back into the circulation. And now that that uterus is getting smaller, there's more return or easier return of blood from the abdomen and the lower part of the body back to the heart. So all of this causes an increase again in blood return back to the heart and can increase the heart's workload in the first couple of weeks, even the first couple of months in the postpartum period. And so these are a time frame where women can still be at risk of having things like heart failure symptoms or rhythm issues. And so I frequently will ask my patients to check in with us maybe a month or two after delivery to see how they're doing and make sure that they're transitioning back into the postpartum period without having many heart-related problems. Now, in terms of long-term effects of pregnancy on the heart and cardiovascular system, there really is not a whole lot of data out there about long-term effects, but there is a little bit. And there's some types of congenital heart disease where it's thought that potentially there may be a stress that's on the woman's heart during pregnancy that does the heart recover after the pregnancy. And some of those could be in women, like I mentioned before, with that Fontan type of heart condition where they have one ventricle pumping the whole body's cardiac output. And sometimes the workload of pregnancy, if we see a reduction in heart function, sometimes the heart function will get better, but maybe not back to the normal pre-pregnancy level. We've seen that in a couple of our women that have become pregnant and delivered with in the setting of having a Fontan or single ventricle. I mentioned something called postpartum or peripartum cardiomyopathy. That's another condition where potentially the heart may not come back to a normal or pre-pregnancy level in terms of function after a pregnancy. So these are things that for women with heart disease, congenital heart disease, or even acquired heart disease, that when they're seeing a cardiologist and other providers like maternal fetal medicine doctors, these are things that they can discuss with these providers during their either preconceptual counseling. That's probably the best time to do it, or during the pregnancy itself.
Thank you for sharing that. And then this question is kind of posed to all of you guys, is what advice do you have for CHD patients considering pregnancy or who are expecting moms?
I would say just to follow up with all your providers, just making sure you're going to all your appointments, getting your levels checked if you need labs done, and just being an advocate for yourself, and just try not to stress too much, just knowing that you have a lot of people watching over you and baby.
Yeah, and I would echo that, and thanks to Steffi and Cassie for joining us and sharing your stories. But I would echo the same exact thing, that again, having good follow-up and talking about risks of pregnancy and risks related to mom and the baby before pregnancy. So preconceptual counseling, making sure that we know what your heart status is like before conception, so we know how your heart will handle the increased workload of carrying a pregnancy, and then being followed during that pregnancy by a team that has specialty in terms of managing pregnancy in the setting of heart disease. And that's often like a multidisciplinary team. Like I mentioned, we have here with Children's and Freighter that includes cardiologists like myself in adult congenital heart disease, or general cardiologists that manage women with heart disease that is not congenital, and then maternal fetal medicine doctors, OB anesthesiologists, and then having the resources available in case we need other specialists like heart failure specialists or interventional cardiologists or ICU doctors. So a very large collaboration of different disciplines to help the woman and the baby have the safest pregnancy and labor delivery possible.
I'm all about, as a fetal cardiologist, I see the moms that are pregnant to see the babies, but I'm all about planning. And whether that's planning and starting from a young age of planning to make sure that you always have a cardiologist for your child, if they need that as they grow up, that we are really good at fixing and getting kids with heart disease better, but as they grow up, that they're always going to need that cardiologist to kind of be on their team, so that even when unexpected things happen, unexpected pregnancies, great surprises, that that there's still a team in place that can be there for them. I think the other part, as a mom, if a mom is pregnant with a baby that has heart disease, planning goes into that too. And so keeping appointments and making sure that you understand and can advocate for what not is just part of your birth plan, even though it might look different, what is best for the baby, and if there's things that you don't understand, to ask questions. So planning and asking questions, making sure that you understand what is being asked of you and asked of the baby, what do they think is safest, that's all really important too.
Well, thank you guys so much for joining our webinar today, and especially to Steffi and Cassie for sharing your experience as well. We always try and make sure we bring in that patient and parent perspective into our webinars. So thank you for joining us. And once again, Dr. Cohen and Dr. Creighton, thank you for sharing your expertise with us.
Thanks for
Thank
having
you.
us.
Thank you.
Absolutely.
Thank you.
Thank you.
Bye.